This is the first episode of our SADS Expert Insights webinar series. And so this series is here to work alongside our live stream program to help further our patient education efforts. And the goal is to feature some of the latest topics in the realm of SADS conditions. So things will be a little bit different versus our live program if you've been keeping up with that. It's a more lecture style webinar with 5 to 10 minute Q&A period where you can ask an expert your questions. And so you can just feel free to, if you have any questions, put them in the chat and we'll be sure to get those answered. It should be easy today. This program is also going to be recorded for your convenience, and so everyone that registered will get a recording of this. We'd like to thank our sponsors, Action First Aid and Save Station, who have supported our efforts in helping to offer these educational programs. And so with all that being said, I'm going to stop talking and introduce our speaker, Dr. Stephen Brooks. Dr. Brooks is a clinician scientist in the Department of Emergency Medicine at Queen's University. His academic focus is in cardiac arrest and resuscitation. He conducts studies on innovative technologies and strategies designed to increase bystander CPR and improve access to early defibrillation. Dr. Brooks is a member of the Resuscitation Advisory Committee of the Heart and Stroke Foundation of Canada and the immediate past chair of the Science Subcommittee within the American Heart Association Emergency Cardiovascular Care Committee. He has been involved in the development of international emergency cardiovascular care guidelines for the last 20 years. And he is also the Chief Medical Officer for Rapid Response Revival. So, Dr. Brooks, I will let you take it away from here.
Thank you so much, Evan, and thank you both to Pam and Evan for the invitation tonight. And I hope this talk will be of interest to all of your members. And this is something that is close to my heart as far as my passion for really trying to improve outcomes from related to out-of-hospital cardiac arrest. I'm going to be speaking about a few things. I have some slides prepared, which I'm just going to pause for a second and share my screen, and we'll just make sure that they're projecting correctly. Just give me a second. There we go. Just looking for a nod from Evan to make sure that's projecting okay. Awesome. All right, so I'm going to talk to you about involving the community and things we can do with the community to improve the response to cardiac arrest when it happens in our communities and ultimately improve outcomes related to out-of-hospital cardiac arrest. And I'm going to tell you about 3 projects that I'm currently involved with and working on that relate to those things. So just a few disclosures, just so you know where I'm coming from. As Evan mentioned, I am a clinician scientist and academic. I do emergency medicine shifts in Kingston, and the rest of my time is spent doing research in this area. But I also have a job. I'm a compensated chief medical officer at this company called Rapid Response Revival, which I'm going to be talking about today, and I'm going to be showing you the Cell8, which is the device that they make. It's important that you know that I work for that company when I'm speaking about the device. You can see some other things listed on the screen here. I've received in-kind support and funding from these organizations, and I think many of them are going to be mentioned in the presentation. Specifically, I as well am supported by your sponsor, Action First Aid Save Station, an amazing commercial partner working in this space and doing amazing things. They donated 80 AEDs for our community responder program that I'm going to be telling you about today. And you can see some other groups that have provided funding for my research. Okay, so let's get into it. And I hope to go through this, and then if there are any questions, I'm really hoping to be able to answer them at the end of the talk. There are 35,000 out-of-hospital cardiac arrests that happen in Canada every year. That's a mind-blowing number. These are sudden, unexpected. They often occur without any warning. And as many of you know, this is something that can impact people at any stage of life. Unfortunately, about only 10% of people in Canada who experience an out-of-hospital cardiac arrest survive to hospital discharge. So we obviously have a lot of room to work and improve those outcomes, and that's what drives me and my research. Here's the challenge we face, though. For every minute that passes when cardiac arrest occurs without something being done, and that's something being CPR and use of defibrillator, chances of survival decrease by 10%. So that's 10% for each minute that nothing is being done. Unfortunately, in North America, even in the most well-resourced cities and regions of our country, when you call 911, on average, it's going to take about 6 minutes for the ambulance to arrive. So when we're talking about 10% reduction per minute, when nothing is being done, 6 minutes is really the difference between life and death, and it's just not fast enough. So as a result of that, we really depend on what happens before the ambulance arrives. And that action by bystanders, by people who witness the event, really has everything to do with whether that person survives or not. And we've had a lot of emphasis, in our work. And when I say our, I mean scientists, trainers, policymakers. We've really focused a lot on optimizing paramedic care and ambulance care and care in the hospital. That's where a lot of interest has been in the last few decades on trying to improve outcomes. But really, I think where we need to shift our focus is more to the beginning of that chain of survival, related to what happens with early recognition, early CPR, and early AED use. Because if we can improve those links in the chain of survival, we can have a much greater impact on the population rates of survival from cardiac arrest. Unfortunately, though, our current approaches really rely on luck when it comes to bystander CPR and bystander AED use. And this is evident, and I would challenge you, if you're bored and looking for something to Google, if you Google, survivor, cardiac arrest, CPR, AED, those kind of terms, and you look at stories in the news about cardiac arrest survivors, you will find in most of them the word luck is either in the title or plays a main role in the story. This is an example, some text here talking about how this person had a few lucky breaks. There were police nearby and they started CPR. There was also an off-duty nurse who just happened to be around, and this person survived, but it was because they were lucky. They were lucky that somebody was around, knew CPR. And you see that again and again in media stories. Here's another one. They were lucky again to have sort of a doctor who knew CPR beside them while an ambulance was called. Unfortunately, most people aren't that lucky. So when we look at the rates of CPR for people who have their arrest outside of a home and outside of a hospital, so in a public setting, only 45% of cases have bystander CPR done. And when we look at the rate of bystander AED use, so despite all the investment and all of the focus on public access defibrillation programs, we currently have about 8 to 10% use rate in out-of-hospital cardiac arrest. So only 8 to 10% of people who experience cardiac arrest in a public setting get a bystander to use a defib on them before ambulance arrives. The problem gets even worse because 80% of all cardiac arrests actually happen in homes. They don't happen in train stations or schools or community centers. They happen inside a residence. And unfortunately, the situation with CPR and AED use is even worse. So only a quarter of cases of people who have cardiac arrest in their home receive CPR, and about 1% or less get the use of a defibrillator before paramedics arrive. And that's not surprising because our technology, our conventional AEDs are expensive and bulky and really not targeted towards the home market. So most people don't have a defibrillator in the home. They might have a fire extinguisher, they might have a smoke detector or other safety equipment, but they usually don't have a defibrillator. So we're really left to rely on luck when it comes to cardiac arrest in the community. And my research and a few things that I'm working on relate to strategies that try to reduce our dependence on luck when it comes to cardiac arrest. So I'm going to tell you about 3 of those today. One is called Pulse Point. The other is called the Neighbors Saving Neighbors program. And the last thing I'll talk to you about is an innovation in technology called the Cell Aid. So first of all, many of you have probably heard about Pulse Point, but for those of you who haven't, this is a mobile device application. And this software strategy essentially lives in the computer-assisted dispatch systems in the 911 center. When a call for cardiac arrest or suspected cardiac arrest comes in from the community, actually, let me just back up before we talk about the call. When Pulse Point gets implemented into a community, there's a campaign in the community to essentially encourage people in that community to upload the mobile app onto their phone. And those people who bring the app onto their phone, if they are trained in CPR and willing to do so if asked, they essentially click a little button in the app, and then they're identified in the system as a potential responder. And this is an example of the uptake in the San Francisco area. Each of these yellow icons is a user of the app. So this is sort of a live shot of people in the San Francisco area with Pulse Point app on their phone. So you can see, whereas before you might have had a few ambulances roaming around or in their stations, now in the San Francisco area and other places where Pulse Point is being implemented, there are literally thousands of responders standing by to respond. So when a cardiac arrest does happen in a Pulse Point community, the 911 call happens as usual. When the call taker identifies the address and the location and puts it into the computer, the Pulse Point system in the background identifies the cardiac arrest based on the codes that the call taker is putting in. And essentially the system draws a 400-meter radius around the emergency. And anyone with the app on their phone within 400 meters of that emergency, indicated here by the red pin, gets a message, gets a notification. And it looks something like this. So you get a notification on your phone. It says CPR is needed, gives the address. And when you open that notification, it opens the app and it gives you directions towards the emergency and also notifies you of any nearby public access AED that's being listed. So essentially, it's crowdsourcing basic life support for cardiac arrest. And in that way, it's designed to try and make bystander response a little more purposeful, a little more part of the planned emergency response through 911 to cardiac arrest in the community. And the hope is that by having thousands of people around, for each cardiac arrest that happens in our community, there will be somebody within 400 meters and they will be able to respond and maybe even pick up a public access defibrillator. This is an example of an alert that I got on my watch sitting in my office at Queens. It turned out that this was a first-year student who had had a little bit too much to drink the night before and fainted in class. So they didn't need CPR and they were okay, but this was my first call with the system, and it was successful. My team has done a review of the literature just recently, and we've identified that these kind of technologies, so things like Pulse Point, are proliferating. And these kind of systems are now in place in 23 countries around the world. These are some of the most popular, successful ones. Good Sam is in the United Kingdom and has more than 1 million users. Sove Life is in France. The Heart Runner app is in Scandinavia, and the My Responder app is in Singapore. So this technology is being implemented quite broadly. Here in Canada, I was so impressed with the app, and I thought that it could have a huge impact. So I brought it to Canada, and we implemented it in the entire province of British Columbia, where it is currently active. And then we also have it in place in Winnipeg, and actually we have it in Kingston as well. We decided that because this was such a new technology and it had so much promise, but also it does have costs. There are risks to theoretical risks to patient privacy and patient safety. You're really trying a totally new approach here by kind of including anonymous bystanders in the professional organized response to cardiac arrest. We felt that it was necessary to undertake a randomized controlled trial, or RCT. So we got that funded by the Canadian Institutes of Health Research, and this study is currently ongoing. And we're essentially randomizing cardiac arrest calls to either receive activation of pulse point or not. And we're going to measure the impact of having the system active. Hopefully I'll get that published within my lifetime. It's been a challenge with COVID, as you can imagine. So switching gears a little bit, one of the limitations of the pulse point system is that because the users are anonymous, and because of the design trying to maximize the number of people who sign up, it involves anonymous users who self-proclaim that they're trained, and many, if not all of them, are not equipped with an AED. The other limitation is that pulse point only activates on public location cardiac arrests, meaning out in the public, not in the residential areas. It was felt with anonymous, untrained, kind of unvetted users, it was a bit too risky to be calling them into people's homes, where the risk to both the patients and perhaps the responders was escalated. So pulse point only works for those 20% of cardiac arrests that happen in public. Fast forward to 2018 now, my family and I had the great privilege of living in Scotland, which you can see here on the screen. And I lived there on sabbatical, working at the University of Edinburgh with a group there doing similar kinds of cardiac arrest research. Now, Scotland has a significant problem with cardiac arrest and cardiovascular disease because this is what they eat for breakfast every morning. And I can guarantee you it's delicious. And there's a reason why they're eating it every day, but it does lead to some cardiovascular problems along the line. So they have a significant problem like we do with cardiac arrest. And like Canada, they have many rural areas that are difficult to reach quickly when an emergency happens. For many years, people in the United Kingdom and systems in the United Kingdom have employed the model of community first responders. And this has been going on since World War II, where, especially in these smaller towns and villages, there are trained members of the community who respond in parallel with paramedics. And because they're embedded in the local communities, often arrive first. And community responders in the UK are dispatched for all sorts of different emergencies, including falling elders, trauma, chest pain, strokes, and all sorts of medical emergencies. When I was in Scotland, I learned about this initiative. The Sandpiper Trust is a charity that was started by a family who, while on holiday in Canada, unfortunately lost a young child to drowning in a rural area in Canada while on holiday. And after that tragedy, they decided to start a charity that was focused on improving emergency response in rural and hard to reach areas. And fast forward many years later, they designed this program that they called the Wildcat program to focus on cardiac arrest in rural and remote areas. And so they started the Wildcat program. They recruited volunteers, mostly lay people, from these hard to reach communities, trained them in CPR, equipped them with defibrillators, and then also gave them a way of being dispatched by the emergency services. And so when I saw this, I was amazed just at the community they had built, the enthusiasm of all the volunteers, and they were able to shave 5 to 10 minutes off their average response times, which doesn't sound like a lot of time, but in cardiac arrest, that can be really the difference between life and death. So when I was in Scotland and thinking about home and about how much rural space we have, and even in cities in Canada, how much delay there can be between a 911 call and responders arriving, I thought that this was a really important thing to maybe bring back home and test as well. So this is my neighborhood. I live in Kingston and work at Queens, and Frontenac County is the township that Kingston is in. And it's outlined in gray here. It's quite a large area. mostly rural, with many small communities in that region. And this is just a snapshot in time, as you can see, from 2014 to 2020, of the highest priority ambulance calls. So we call them CTAS-1 calls. And you can see that the dots in red throughout parts of the county outside of Kingston, this big blob of dots is Kingston down here, but up outside of the city, there are many high priority calls that have a greater than 10-minute response time. And in fact, the average time for volunteer firefighters to respond to these is sometimes up to 20 minutes. So we clearly had a problem in responding to cardiac arrest, which of course are these CTAS-1 calls. And I thought we should get to work on this. So I gathered these partners here. Frontenac Paramedics is our local EMS, and got some funding. And we developed what we call the Neighbors Saving Neighbors Volunteer Responder Program. And this started way back in 2018, and the pandemic again kind of slowed things down. And we've been working on it since 2018. And I'm really proud to say that on March 28th, we launched in Frontenac County, and we started to recruit volunteers. Essentially, we vetted these volunteers. They had a criminal background check. They applied, we interviewed, and then approved the volunteers. Those who were approved were trained in CPR. They were given equipment, including an AED and personal protective equipment, a high visibility vest, and a volunteer ID. And they used the app, the Good Sam app that I mentioned earlier, on their phones. And that is the mechanism by which our 911 operators activate our volunteers when there's a suspected cardiac arrest. And they use the app to get a map direction there, and they can also communicate back and forth with 911 as they're responding to get more information. So we put out, a wide call in our community, tried to get media engaged in social media, word of mouth, and we put out these flyers in community centers all throughout the region and stores and things like that. And we were very happy to get a great response. Volunteers needed to do an online training session for about 4 hours, and then they needed to come for a full day of training in CPR and AED use. And this is the temporary Frontenac Paramedics headquarters with stuffed animals included. This is like a conservation area learning center that they're temporarily in while they are renovating their headquarters. So here's some of our happy volunteers graduating and holding up their AED and equipment pack, and they're heading out into the community, and they've got their app on, and they carry this equipment with them in their car or keep it in their house, so that they are ready to respond when they get an alert on their app. This is just a picture of the kit that they carry and the types of defibrillators that we're using. And again, these were donated by Action First Aid Save Station. They were refurbished, brought back from clients like Hydro One who were, getting new equipment or something like that. But without their support, we obviously couldn't afford, 80 defibrillators to support the program. This is just a screenshot of the Good Sam app that dispatches the volunteers, just as an example. An alarm goes off, it's like a loud ambulance siren, and then you acknowledge and you say whether you're able to respond or not. And the app searches for 3 volunteers minimum within 10 kilometers, and the volunteers will drive to the scene, much like a volunteer firefighter, assess and confirm cardiac arrest, start CPR using the AED, and then hand over control of the scene when paramedics or firefighters arrive. So because this is so new, and again, there are costs and risks, and I think if it's going to take off, we have to convince policymakers that it's working and that it's safe. So we are undertaking a study of this pilot and looking at safety, feasibility, and effectiveness. The future hope is that we'll be able to take this program, and with our partner Heart and Stroke, who's already branded the name of the program, that hopefully this will be like a modular offering, so other communities can, who are interested, can kind of take the program and implement it in their own community. That's my hope, that will be able to use the branding, so the brand power and the experience and expertise and resources and training that Heart and Stroke has, and basically make this like a new level of offering to communities who are looking to implement this. If you're interested in learning more about the Neighbors Saving Neighbors project, you can scan this QR code and it will take you to our website hosted by Frontenac Paramedics, and you can learn all about the program. And if somebody in Frontenac County is looking at this, then you can volunteer for the program as well through this QR code. I'm hoping to make this available in many more communities across the country over the next few years, and we're certainly keen to do that. So just moving to the last topic here, and then hopefully we can have time for questions if there are any. I wanted to just talk to you about, defibrillation and what we've been doing to try and improve access to AEDs, basically, when cardiac arrest happens. And I want to talk to you about really exciting evolution in technology that's essentially moving us from what now is really a focus on public access defibrillation, and instead moving to personal access defibrillation. I'm going to show you technology that I think is similar to the move from the telephone booth, like the public telephone booth, to the mobile phone. The device I'm going to tell you about, again, this is the company that I work for, so just keep that in mind as I'm speaking. The product they have invented is called the CellAid. And this is the device. So it's the world's smallest and most affordable defibrillator. And the idea is that this is not a defibrillator to be stuck on the wall, although it can be. This is a defibrillator to be carried on the person, or have in your car, or have in your home. This is designed as consumer grade defibrillator. So not a piece of heavy medical equipment that's meant for an ambulance or a hospital, but something that's meant to be carried around. And the reason why I have aligned myself with this company is because for many years, I had been working on these solutions that were complicated workarounds, basically for barriers created by technology. So, I was looking at drones, delivering the idea of drones, delivering AEDs during an emergency. These community volunteer responder programs designed to get AEDs to people quickly. These are all complicated, complex programs that are all trying to deal with the fact that AEDs are expensive and bulky, and there's simply not enough of them around. There was a recent study in the UK looking at all the public access defibrillators in the UK, and there's 72,000 public access defibrillators in the UK, and the average walking time from the center of any postcode in the UK to the nearest public access defibrillator is 19 minutes round trip. So they're just simply not accessible when you have your cardiac arrest in your home. You just don't have access to public access defibrillators. So the reason this came about is because Donovan Casey, who's seen here in this picture, he's the inventor and founder of this company. So this thing is not coming from a defibrillator company. It's coming from a person who was sitting in bed with his wife one night years ago. He was studying for his master's. She was reading a book before going to sleep. And she started making some unusual noises. Turned out to be she was having agonal breathing, and she had actually slipped into cardiac arrest. And Donovan recognized she was sick, obviously very ill, called their emergency services, and they were very lucky, there's that word again, that there was an ambulance that just happened to be returning from a call just literally seconds away from their house. Paramedics arrived and continued doing CPR and shocked her a few times, and Sarah, Donovan's wife, survived. When it was time for Sarah to come home to the house, Donovan went looking. He went shopping for a defibrillator, and he was shocked to find that it was going to cost him a few $1,000s, and that everything out there seemed to be designed for medical professionals. They were bulky, and he felt that he was a customer for a product that didn't exist. He wanted a personal home defibrillator that was suitable for a layperson like him. So apparently he took apart a conventional AED in his garage with a fellow engineer, and they figured out how it worked. They consulted and collaborated. They did their research, and they were able to essentially miniaturize a conventional AED and make it more affordable and more portable. So this is what they've invented. This thing weighs 290 grams, and that's about the weight of a human heart. It is a single-use defibrillator. So that's the difference, is that you just use it once. So think of it like the fire extinguisher that you have in your home. It's meant to be used once. You'll probably never use it, but if you do, it could be really important. And everything is integrated into the one package. The two halves, when you turn it on by breaking it in half. And then the two halves of the device become the electrodes. And it can supply up to 20 shocks. It gives you the verbal instructions of how to do CPR, just like a conventional AED. It's connected to cell signal, so it can send the data from the event to the patient, and also kind of email the owner when the batteries are running out or when the device isn't resuscitation ready. So, and the other thing that they've done is understanding that most people can't afford a $1,500 to $3,000 defibrillator in their home. The focus is on trying to reduce the price. So once it comes here, it will retail for around $250 to $300 instead of $1,500. So that was from the beginning, that was their mission, is to make defibrillators more accessible. And I think that this technology, there are other companies that are innovating and taking the defibrillator from a big box fixed on the wall to a smaller portable thing that's meant for your home or your bag or your pocket, literally. So Cell8 is not the only one, and I'm happy about this because I feel like it's long overdue that we innovate AED technology in this way, because it opens up all these amazing possibilities of where we can get defibrillators easier. Again, thinking about the in-home use, I have one. This is mine here in my nifty little bag. I keep it in my backpack all the time. Think about giving it to our community responders. So the Neighbors Saving Neighbors responders in other communities, if we don't have the budget to give every responder a full conventional AED, we can potentially equip them with these smaller ones. Think about offering them to course graduates, right after they've learned how to do CPR, they've just heard about the importance of early defibrillation, and now they can take one home with them. Mobile medics, police officers, bike medics, where size and weight is important. Marathon personnel, where you might have been able to afford one, now you can afford 5 and just get them in more places than before. There's even maybe an argument to look at having them bedside for every patient in the hospital rather than having to wait for a crash cart. So those are just a few examples, but I think, this is like the technology was the barrier, and now some of these barriers are going away, and we have opportunities to think about, how we can take advantage of that. So again, the QR code here will take you to a white paper that I co-authored on the defibrillator. And for those of you who are interested in how it was miniaturized and how it works, and the rationale and the story behind why it was invented, you can read it there on the QR code. I'll just leave that up for another second, but that's what I wanted to tell you about. Those are 3 projects that I'm really passionate about, because I think they're different ways of tackling barriers to getting people earlier CPR and earlier defibrillation when they have their event in the community. And that is absolutely critical if we're going to push the needle on survival, is getting those things done more consistently and earlier for people. So I'm going to continue this kind of work, and I hope that if anybody watching this, because I know the crowd online here is fairly small, but if anybody's watching online later and you would like to discuss these things further or learn more, please contact me, and I'll just put my email up right here. Please reach out. I'd love to have a conversation with you and learn about how we can collaborate on these things. So I'll stop there, Evan, and thank you very much. Happy to take questions if there are any.
Yeah, I have some that were submitted beforehand here, and I think that you really touched on a lot of this, but we'll just go through them. So one of these
Sure.
is just, how can individuals with SADS conditions best prepare themselves and their communities for sudden cardiac events?
Yeah, this is really important. And I think people with pre-existing conditions that are at particular risk for cardiac arrest, the need to have a bubble of people around them and a community that are very well informed about what cardiac arrest looks like. So early recognition is so important. That's step one, because we know that many times there are long delays related to lack of recognition. People often mistake cardiac arrest for seizure or fainting or something else. And that includes not only bystanders, but sometimes the 911 call takers. With the information that's being provided, there's been many cases where there's been just terribly delayed recognition of cardiac arrest. So I think that's important, helping people understand that anytime someone is unresponsive and not breathing normally, that is a reason to initiate CPR, call 911, and get a defibrillator on the scene. Secondly, of course, it's just awareness of and also confidence to start chest compressions. That is the most critical step in the bystander response. So it's making sure that people in schools and people within the circle of people with SADS conditions know about CPR and they're confident to do it. That's really important. And then as well, just making sure that there is access to an AD in places where SADS individuals are frequenting, and whether that's schools, community centers, and now maybe with the advent of new technology, having defibrillators around carried with them is now an option we didn't have before. So I think for me, those are the most important things. And those things are important for anybody, any community, but I think even more important for people living with SADS conditions.
Yep, definitely very important. And then there was another question on how do you feel about the current training for the public on CPR and AED usage? Are there areas of improvement?
These are amazing questions, and I think, in my opinion, CPR, cardiac arrest awareness, recognition, and CPR and AED skills should be considered life skills for everyone. And in my opinion, it should be a mandatory part of our curriculum for young people in school across the country. In my opinion, I think we should be teaching it as part of our routine kind of health teaching in school. And I think it would be a failure of our school system that kids graduate from high school without knowing what cardiac arrest is and how to do chest compressions and how to use an AED. There are jurisdictions across North America, Canada, the UK, and other places where there are movements towards making this mandatory and making it part of the curriculum. I think the challenge is sometimes the first step is getting it on the radar and getting it into the curriculum. The second is supporting teachers and schools to have the resources and the confidence to be able to teach that, actually get it done in the school. So it's not easy. I'm not saying that's easy, but in my opinion, we really need to make this a part of basic life skills and raise the profile of cardiac arrest safety like we all know about fire safety. So our kids at school, for instance, go through fire drills and now, unfortunately, active shooter drills, but we don't routinely have an emergency plan in place and awareness and understanding about cardiac arrest. And I think we need to move towards that.
Yeah. And the last question that I have submitted here is, and I think you might have touched on it, and there may be an ongoing study, but are there any recent studies or trials that show promise in improving early defibrillation rates?
Yes. So there are several. And there are so many different strategies being employed. And I mentioned briefly the issue of drones. drones are being explored as a way to get AEDs to the scene quicker. And different models of drone delivery are being tested around the world. There was not several months ago, there was a news report and media that made the media of the first person who was actually saved by a drone delivered AED in Scandinavia. So, we've had proof of principle of that strategy, but I think the real challenge is in logistics and feasibility and cost of drone system to deliver AEDs. That's one example of kind of a real innovation that is being looked at. I think by just on the drone thing, I think we really need to get to the place where drones are being used for utilities and other things routinely, and they might be equipped for carrying an AED and might get reassigned. I don't think it's economically feasible to create a sort of fleet of drones just for AED delivery, in my opinion. There are many studies going on looking at community responder programs. There are studies involving cell aid, for instance, ongoing in Australia and in Singapore, involving the equipping of community volunteers with these small miniaturized defibrillators and measuring the impact on that strategy on times to defibrillation. So those are the major ones that I'm aware of. There's lots of people still looking at ways to improve public access defibrillation with registries and maps and the apps that I mentioned, PulsePoint. There are a number of studies looking at those sorts of things as well.
Lots to look forward to in the future, it sounds like.
Yes.
So that's everything that I have submitted here, and I don't know if there's any more questions. I don't.
You have a question.
Okay, perfect.
I have a
Hi,
question.
Lori.
Dr. Brooks, thank you very much for all your good work. And it's amazing technology that might come into play. I have an adult son who has an implanted defibrillator. And I'm wondering, how does a first responder respond to someone who goes into cardiac arrest and their defibrillator may or may not go off? Do they do CPR? Do they use an AED? What do you do if someone goes into cardiac arrest?
Excellent question, and one that comes up a lot when we're talking about in our CPR classes and when we're talking about defibrillation. There's a lot of questions around pacemakers and ICDs. And for those of you who are listening, ICDs, of course, implantable defibrillators that look similar to a pacemaker, a small box underneath the skin that has wires internally, and allow for defibrillation in the event of an arrhythmia and cardiac arrest. So the important thing is that anyone who experiences a cardiac arrest, regardless of whether they have an ICD in place or not, needs CPR and should have an AED applied. And if someone is unconscious and not breathing normally, and they have an ICD in place, it means that they have, they're in cardiac arrest, and for whatever reason, the ICD is not working to reverse that situation. So absolutely, someone needs, in that situation, needs CPR and the use of an AED. The only difference in the use of an AED when dealing with someone who has a pacemaker or an ICD implanted is the advice is just that you don't place the pads of the AED directly over the box associated with the pacemaker or the ICD. Most of the time, it's not even an issue because most times it's on a person's upper left side of their chest. That's where they're routinely placed. And it's pretty rare that somebody will have the box over on the right side where an AED pad would go. So it's usually not an issue, but if it is, you just simply find the space adjacent to the box that's not directly over it or touching it, and you do everything else the same.
Thank you. So there's no conflict or competition between the defibrillator and the AED?
Not in the sense that they're going to interrupt each other. The
Okay.
AED will go through its normal process of interpreting the rhythm. And if the
Yeah.
rhythm is deemed shockable by the AED, regardless of whether there's an ICD there or not, it'll provide a shock. And it may be that the ICD is doing the same thing and interpreting the rhythm and applying the shock, but there's very little risk of, you know, the two applying a shock at the exact same time. And again, if someone's unconscious, not breathing normally, they need a shock in the case of a shockable rhythm as soon as possible. And if that is occurring, it may be because the ICD isn't working. You know, it stopped working.
Yes.
And
Yeah.
so the AED is almost, you know, it's important because it may be backing up a faulty ICD.
Right.
The other reason could be that it's a non-shockable rhythm, which happens sometimes, of course, in which case the AED placed will interpret the rhythm, not suggest a shock, but it will support the rescuer by coaching them in CPR.
Okay. That's very good. Thank you very much.
No problem. Thank you for the question.